that for you to access these services. Okay, thank you very much, ladies and gentlemen. CPA Chrispinus Barasa, the County Executive Committee member for Health and Sanitation. With me here, I also have my team, my staff, County Director of Health. We also have our Chief Officer who will be joining us, and also members of the County Health Management team who are here with us. Just for the purpose of being in record, because it's very important, I think we will just do an introduction so that for the purpose of knowing who are present here. We'll start from in charge of. You can introduce yourself and what you do. Yeah.
Good morning, team.
Yeah.
I'm called Madam Mbinyo. I coordinate reproductive health subsystems in the country as well as commodity.
Thank you.
Thank you.
Good morning, team. I'm Simon Smith, Partners Liaison Officer in the Department of Health and Sanitation.
Good morning, team. I'm Juliet Wankana. I coordinate nutrition services and activities in the department.
Good morning, team. I'm Wambus Moses. I coordinate malaria program.
Good morning, team. I'm Joanne Wasike. I coordinate medical laboratory and services as well as our medical health products and technologies.
Good morning, everyone. I'm Robert Mose, coordinate health association and supportive services.
Yes, good morning. My name is Wangila. I'm the County Monitoring and Information Officer.
Good morning, team. My name is Mika Nyairo. I coordinate sanitation and hygiene services in the county.
Good morning. My name is Kelvin Mengesa. I support and coordinate ICT and digital health.
Good morning. I'm Edgar Barasa, economist. I'm in charge of planning and budget.
Morning, board. Nambisi Hospital. I coordinate rehabilitative services and sub-ministry.
Dr. David Wanikena, the medical superintendent for Webuye County Hospital, and also I coordinate medical and specialized services within the county.
Thank you. Good morning, everyone. My name is Dr. Onambisi Caleb Wata. I'm the County Director for Health and Sanitation in BUNGOMA County. As well, I'm the lead technical person to this team as a chair of the County Health Management team. Thank you so much.
Okay, thank you very much. First, we want to appreciate the media for being here so that our people, so that they appreciate what health is doing. As I indicated earlier, I head the Department of Health, followed by chief officer and the director. And to ensure that health services are being carried out properly, we now have a team called the County Health Management Team, the ones that have been introducing themselves here. And their main role is actually to provide supervision services in terms of ensuring that quality services are offered to the public. And that's why most of the time you will see them outside there, checking what is going on in all the facilities. And down there, we also have in all sub-counties, we have medical superintendents who are managing the hospitals, but we also have sub-county MOH. Those ones head also a unit which is called the Sub-County Health Management Team. That team, they also assist in terms of supervising the sub-county operations, and that is not limited to public hospitals. It also includes private hospitals in terms of their discharge. Then in terms of also governance, every facility from the sub-county to the level 2 and 3, we have committees. Level 2 and 3 are headed by hospital management committees, which oversee the operation of those facilities. At the sub-county hospitals, we have the management committees, which also ensures they oversee the operation of those hospitals. In the county, we have one referral hospital. That is BUNGOMA Referral Hospital. We have one county hospital, that's Webuye County Hospital. We have 54 health centers and around 113 dispensaries spread across the counties. In terms of staff capacity, we have over 2,500 staff in health spread across the health sector. Today, and also not to forget the CHPs, those are community health promoters. Those are critical, those are level 1, critical health providers. And they are around 3,580 down there. And those are now the one, and they are also structured in a way in units. I think each one will form a 10-member team, forming a unit down there, so that they are able to coordinate their activities in terms of providing health services. How do we work in health? Because that is what is very, very important. And also, given the advent of SHA, and that is something that is also an emerging issue. And you have been told very clearly that SHA manages 3 funds, you are aware. Primary health care fund, we have the SHIF, and also the emergency, chronic, and critical illness fund. So those 3 funds are managed by SHA. And one of the things that is also happening here is that the public must be able to know that for you to access these services, you must also know what it entails. because that is where we are having challenges, and that's what we need to appreciate what is going on. Because primary health care services are actually funded by the government, and therefore it means you don't pay anything down there. You receive those services free of charge, and you must know from level 2, level 3, those services are available there. And once you have a situation that require referrals, then that's when now from level 3 they are referred to level 4. And the moment level 4, and you see level 4 can also handles primary health care services as well as shift. Yeah, and remember, to be in shift, you must also know what entails. For those who are salaried, remember, employees, they pay 2.5% as a contribution, but for the public, definitely it depends on your income. And also there are those indigents who governments also support, and also county government, which we are also planning to establish and also support. So what happens to this referral mechanism? Level 4, if they have situation that require critical attention, then definitely they have to refer to our county hospital, which is Webuye County Hospital, or refer to our referral hospital, which is BUNGOMA Referral Hospital. The scenario that we are experiencing right now, you find that it is not just treatment. The condition here is that 1 bed, 1 patient. So you go to a hospital, when you are admitted, it is 1 patient, 1 bed. So you don't expect that when you are admitted again, you will get another person admitted that you are sharing. No. With the share and conditions that are there, is that once you are admitted as with 1 bed. But what experience have we had in the past is that no one expects that when you visit a hospital, you are told the beds are full. No one expects that answer. They expect that once any person who visits the hospital must be admitted. But what is we are experiencing now, like for example in the BUNGOMA Referral Hospital, Webuye, you find now, because Referral Hospital does not serve just BUNGOMA. It serves beyond BUNGOMA, from Busia, Kakamega, and also Trans Nzoia. So that means we must completely understand what is required of a referral hospital. What are they supposed to offer? They are actually supposed to be positioned, prepared. They should be actually all the time prepared to receive emergency cases that are beyond level 4 and even level 3. That means they walk in, you come, say we are going to a referral hospital, we want services. That means you might be going there, but those services can be offered in the health center and can be offered in the level 4 hospitals. Like for example, in our referral hospital, SHA does not cover the outpatient. You get? So if you go to the outpatient, definitely it means you will pay cash. It was not covered under SHA. But you go to a level 4 there, you will get that services. You go to a level 2, you will get those services under SHA. What does that mean? It means the public must appreciate that. What happens if we have a critical case from, let us say from Sirisha, a health center, or from level 4, and they are coming to referral hospital and it's full? Then it means they have to refer to Eldoret or somewhere else, because everybody wants to come to a referral hospital. And that is the major problem we are experiencing. But we are telling our members that for us to position, because you don't know tomorrow if you will be found in a critical situation. You don't know tomorrow. If you are found, the solution should be referred. But how do we help referral to be a referral hospital that serves the public? We must patronize our primary health care facilities, our health centers, our level 4 hospitals. As we are talking, the bed occupancy in our level 4 hospitals is below 50%. That shows that now, when you come to the referral hospital, the only best way they can help is to refer you back to level 4 or 5 where the beds are available. You get? So that we decongest the referral. And that is a subject that the public must appreciate and understand. And we are going outside there. We are actually going also to sensitize them. My team, CECM team, we are going outside there. Just to tell them that let us patronize these health centers we have built. The other critical thing that we really want the public to appreciate, why do we have the county health management team in place? The one they call CHMT. These are a support supervision team. These are the team that actually ensures quality services are offered in all public hospitals and also private. And the reason why they must be outside there, they must provide some advisory to the management on what needs to be done on those facilities. So when they come outside there, they want to understand that you are meeting the standards as a health provider. Same as sub-county health management team. I've also explained why we have boards, committees in health facilities and also the sub-county hospitals. We have them because they need to provide supervision. Where are they coming from? They are coming from the community. These committees are coming from the community. These boards are coming from the community. The members are coming from the community. Why are they providing oversight? Because the services are for the community. That's why they are there to provide oversight on the proper management of those facilities. And also we have programs. We're going also to meet them outside there very soon, so that we also share the challenges and the experiences they are having in terms of how best can we give the services to the people. Something else also that I really want to bring to your attention is, what are some of the critical services we are also offering here? We are having recently, I think, and I think it's still going on, the element of HIV. You know, as we are talking, people know that the HIV is not there. Yes. We are normal, we are operating normal. It's not there. But it is real. That is why we have actually now formed a team. Yeah? A team that should now actually prevent mother-to-child transmission. You get the point? This team, and we had a meeting yesterday, and it's still going on. When a mother delivers, you know, it's very dangerous, because you must know your status, so that you don't transmit, if you have, to the child. And that is the reason why we are encouraging the public, delivery should not be done at home. I don't know if you're getting that. Delivery should not be done at home. Reason, in case of complication, and nowadays, and I think you have heard, I have a staff dealing with nutrition. I don't know nowadays what happens. If someone starts to bleed, I think they always say, let everything go. You bleed to death. So if you are not in a hospital, even now in terms of blood to be replaced, it becomes dangerous. Because of the kind of food we also take matters a lot. And that's why we have a nutrition program that is also happening outside there to educate the people. So this is very important for everybody to know, that when you go to hospital, it is important to take responsibility, not to transmit disease to the child, because that's the future generation. The second thing that we are doing as a department is the issue of adolescent, adolescent, that is teenage pregnancy, and GBV, that is gender-based violence. That program is outside there, and our team is moving across the county to ensure that teenage pregnancy is controlled. And as we have said, even SHA, a teenage pregnant mother, actually SHA covers fully. Once it's known, it's covered fully. And how to identify them, that's why we are saying the CHPs are very key to identify these mothers. And that's why we have a partner that is focusing on this so that education is done. And I think very soon we are also going to have what we call the youth-friendly centers in all the 45 wards. We have a partner who is almost completing that program. Then we roll out so that youth, you can have all your, they can have all their friendly centers, so that in case of anything they want to know in terms of innovative and also in terms of their health status, they are able to be explained. The second issue, and I'm happy we have here our program manager, about people with disability. We now have a center. We are now going to have a certificate for exemption being now processed in BUNGOMA. Now it's a full center. We will not now move to, is it Kakamega or Kisumu? Kisumu. So we will now be receiving it here. The exemption certificate can now be offered in the BUNGOMA County, and that is very important for people living with disability in the county. And also we have a partner who has also joined us, who is also going to offer what we call the impairment, that is a screening machine. You know, when a child is born, may not actually know that maybe he has a hearing problem. He cannot speak. You know, you will realize when already time has elapsed. You can't control that. Now that partner is coming, when the child is born, they test all those senses. Are they operating normally? Once they are confirmed, that is mean we provide assurance that you have no problem. As the child is born, we have no problem to move forward. The other critical infrastructure that is on the, also to bring to attention that I think there was also an issue of what is the status of our morgue in a referral hospital. I want to confirm that we did some renovations in terms of leakages that were there on the roof. Right now we are also now fixing the fridges to conform. So that is already in the pipeline, and things are going to operate normally. If I quickly confirm about what other places progress is going on, Bumula, I think we have a full-fledged maternity wing, and we have already, the only thing that was remaining was a septic tank, which has already been factored in the budget. So we are going to, once we get that fixed, then the whole 100-bed capacity maternity will be operational. The same thing with the Ceresia, 100-bed capacity is also going, we have money in the budget, we are going now to complete it in terms of operation. Sinoko, which is in Webuye East, we are happy to report we also got a donor, that M-Pesa Foundation. We have a modern maternity wing that is there, but they felt they need to renovate it and modernize it. So they gave 15 million just to renovate and also provide a theater alongside that. And I'm also happy, also His Excellency the Governor has also promised to ensure that Sinoko is brought to speed to the highest level of standard, and I think he will be engaging the public very soon, so that he declares actually what the Kenya Devolution Program has for Sinoko, and I think that will be a good day when it will be announced. Chwele, I think that one, happy also to indicate theater is also, we are going to, is already in the budget, and we are going to construct a theater there. Then other areas, we are also happy with national government. has already rolled out the Health Management Information System, Tabibu, Taifa Care. They have already supplied the gadget for level 2, 3, and also level 4. So they are, I was informed that I think in the next 1 week or 2, they should be rolling out. And that will provide now an easy access to health in terms of flow of information. Anybody can access services. In a nutshell, what we are saying generally is that we want to integrate services in Bungoma. Someone was asking, why should a patient move from Bumula to Bungoma referral also, but what he needs is only a specialized attention. We are saying that patient can still remain in Bumula, but a specialist moves to Bumula to serve that patient. A specialist can move to Sirisia to serve the patient there, but we may not move the patient from that point to where the specialist is. We want free mobility of specialized services, and that is why we have developed what we call the referral policy, so that we are able to accommodate those kind of movement. And very soon we are also coming to launch, commission Cheptais. We now have a full-fledged theatre and also X-ray. I think His Excellency the Governor will be launching it very soon, and that shows that the region now is positioned to offer proper health care services. And I think for that, I think I can stop there, so we are able to interact now on matters health. Thank you very much. Yeah.
Azir, before you leave the stage, there's this issue of SHA. Has brought a lot of problem to our patients, and you talked of people being treated in their primary health care system before they refer to these other areas. What actually is happening? Because majority patients are crying out every now and then. Is SHA working?
Yeah, I can assure you that SHA is working, and I want to say this so that we understand. As I said, whenever you are playing, it's like being in a football game. There are rules you need to follow. When SHA came, I think what we are not getting is the rules pertaining to SHA. Like, for example, staff, that's under shift. What they contribute 2.7%. But they say your premium should be paid before 9th. So in case exchequer delays, it means you don't receive those services. And that's what's happening. But as a department, we have now written through His Excellency the Governor, we have written to SHA to provide us an extension period of around 60 days to allow us, for example, if exchequer delays, staff do not fail to enjoy the services. And that is satisfactory enough. And we have already written that letter is with the SHA, and we're expecting that exemption to come very soon. And it will address the complaint around there with the staff to deal with that. With the public, what we need is that the public should ensure that their premium under shift is updated for them to enjoy those services at level 4, yeah, and also level 5. They must update their premiums. If they don't update, it means when you go there, they will say you have not, your premium, you have not paid. So you will not receive those services. You may be sick, but now through SHA you cannot be served because the premium must be paid first. And that is the challenge you are saying. Then number 2, you may go to a referral hospital for a primary care services, yet they are supposed to be forwarded at level 2 and 3, free of charge. And that's what has been indicated. So it is important that what we are saying, we want to do a serious sensitization to the public to understand that simple tests, those preliminary examination can be done at a health center. So once you are given that, in case they are not able to handle, they can do a referral to a level 4, and the level 4 you cannot handle, and it's become very critical, it can be referred to now a level 5. So that at any time, level 5 is positioned to receive critical cases. And that will provide a better environment for our county. Yeah.
Waziri, now that BCRH, for example, is allocated about 300 bed capacity, there are these patients who come and they fail to get treatment, and or you might be having a challenge on admitting more than 300, but we are sure that this hospital should be able to accommodate more than that. What are you doing as an administration?
Let me tell you, in fact, before we were having around 217 beds at the BCRH. It was, every day it was full. We had to write again to upgrade up to 311, which we have now. Again, it is full. Now again, we have written to upgrade it. In fact, the latest letter I wrote was 512. But when the officers also came, they indicated that they want to see physical beds. Now there are 370. So they will approve 370. But the 142 beds, they are already in our work plan to purchase to reach 512. So the problem is that even if we increase up to 512 and the same behavior prevails, it will be full. What we are saying is, why should referral be full and level 4 are below 50% bed capacity? That's why we are telling the public level 4 can give them the services they are looking for in the referral, so that we allow referral to only handle critical cases, so that the others can handle the preliminaries.
Would you then confirm to the public whether we have enough, say, manpower at the level 4 and therefore madawa and equipment to handle the traffic?
At our level 2, 3, 4 have the capacity to handle. That's why I'm saying the traffic is not there at level 2, 3, 4. The traffic is at the BUNGOMA referrals. And that's why we are saying they are trying to put the referral also in a situation they cannot deliver their mandate to handle critical cases because it is full. If right now you collapse here now, we don't know where to take you. Because if you go to the referral, they will say we cannot handle because the beds are full. But if those normal treatments can be handled at level 4 and 2, when you collapse here and you need critical care, the space must be available for you. That's the preparedness that we want to happen in our county.
Maybe there are beds, but madawa kuna staff hawako enough.
I can assure you, and this is one thing that we may not be getting. It is not about staff. It's about the workload. And that's what we are telling everybody. It is not about staff. It's about the workload. How many patients are you serving in a day as a staff? That's what we are looking at, the Department of Health. Right now in the PCRH, what we have done, and it must be, and if you go there, you can confirm. We had a problem where you find when you go to theater, if you have booked you at 8, you realize you go there at 10 or 11. Right now, if you are booked at 8, it must be 8. If you are booked at 9, it must be 9. If it is 10, it must be 10, because there is a monitoring element of performance there. If the patient leaves the hospital, he must fill a feedback form. How did you enjoy this? How were you served? Put it there. Why are we doing that? It's because we want to know these gaps that are there. How do we solve them? You get the point? 3, identification of staff. Right now, all staff must have badges. The referral. So that we are able to identify. If the patient have issues with you, can be able to write your name. That I had a problem with this staff. 4, we have also said any maternal death or newborn death, it must be investigated. And that's why we have a committee in place. That it must be investigated to understand what exactly happened, so that and what could be the immediate response to that matter. And that's why we have a committee in place, chaired by the director, and we have cascaded that in every facility to report on any death and to give reasons why it happened. Because we have no reason to lose life. And that's the condition that we're offering now.
Waziri, you mentioned something about staff. I've several received concerns about interns. They seem to be too many, and most of them do not, basically, according to the patients, they do not know what they're supposed to do. They keep referring on their phones. That is the concern I've seen. If they wanashinda wakigoogle. So I don't know what you have to say about it.
I can tell you for free, that was an issue, but we have already corrected it. Right now, as we're talking, and if you can go and confirm, we have now ensured that whatever the student came to learn, must learn. And they are now having what we call the continuous training in the facility. They ought an officer who tells you came, and they are monitoring their performance in terms of, are you learning what you came to learn as a student? Then every student is given a supervisor. So that when you are going there, for example, as a nurse, and you are going there to deal with a patient, you are not the one. You need to have someone whom you learn alongside. Not you assuming that you are the one in charge. Those are things that we want to close, because at the end of the day, then we will not have a good person who delivers. So those ones we rectified, and is now operational as required.
I appreciate Ziri. I'm glad to hear that from you, that you have rectified it. But as late as yesterday, there was a patient also complaining about students being the one doing it. You know that it has really, the problem that people have had is that it has really interfered in people's the way they take the hospital now, because some people have a feeling. I think what we've gathered is people have a feeling, have a problem with being attended to by students. They have a feeling that the students are attended to them. It has been there, but people have been complaining about it. As late as yesterday, there was someone complaining about it. Now, Waziri, about SHA, maybe for the benefit of those who
let me clear that so that it does not evade. Yeah? I think we must come to full terms that that student is your child. That student must learn. If we don't get into terms with that, that student has been assigned to observe signs from this patient and report to the supervisor. He is not the one treating that patient. There is what we call ward rounds in a hospital. Students don't do ward rounds, they move along the supervisors during ward rounds. But once the doctor has done the ward rounds, he leaves the interns to observe and record. Once they record those observations, they now clearly able to explain to the doctor, this is what I observed, and as they report, they are also learning.
Yes.
You get? While the doctor now goes for the next ward rounds, the student is learning, at the same time the patient is benefiting. That is the logic around the students. Yeah.
Why that is that Waziri, issues with the SHA,
yes,
for the benefit of the one watching maybe live the way it is right now.
Yes.
Could you break it down and understand? Because I think I have a feeling, maybe the residents have a feeling, maybe they have a problem identifying which one is level 5, level 2, level 3, level 4.
Yes.
I think very many people also have a problem with that, apart from you, people who are within the health sector. Maybe for the benefit of the one watching, maybe which one is level 1, level 2, level 3, level 4, for them to understand.
In terms of what services they have?
Yes.
In fact, we have a doctor here fully.
Because
so
that could be the problem why people think.
Yes.
And I've also heard people think, people have a feeling.
Yes.
If it's in Bumula, he has to go to where the doctors are.
Yes.
That is referral.
Yes.
Hapa kuna madaktari wako huko.
Yes.
They have a feeling kwamba daktari competent ones are in referral and they're not here in Webuye or in Sinoko. Maybe if you can just break it down for the benefit of the one watching, which was level 5, level 2, level 3, level 4, maybe give them assurance that they can still get services from wherever they are, like Sinoko or in Kitavisi, and not have to come to Bungoma.
I can, that's a very good question, and I think it's important for the public to know. We have 9 sub-county hospitals in Bungoma County. 1 county hospital and a referral hospital. When you come from this side, we have Bumula sub-county hospital, which is level 4. We have Sirisia sub-county hospital, level 4. Cheptais sub-county hospital, Mount Elgon. We have Sinoko. We have, which else we have? Chwele, Kimilili, and Bokoli, and Naitiri. So that forms the sub-county hospital level 4. Then we have a county hospital, which is Webuye. County Hospital and Bungoma County Referral Hospital. Those ones now are the categories. So when you look at from the dispensary and the health centers, in terms of referrals, they are supposed to refer in that order within their sub-county. And that's why we are saying we don't want a situation whereby we are saying specialists are in Webuye County Hospital, they are in Bungoma referrals. The referral policy we are developing is to ensure that when you are in Sirisia and you need a pediatric, he will go there. She will go there and do the ward rounds that you require, and you will not know because you only need the services. You get the point? Yes. That policy is supposed to reverse that kind of approach so that you don't have to strain to say that if I'm in Mount Elgon, I need to come to referral just for the power to see a gynecologist. You get the point? Yes. They only book a date when you are there. A gynecologist should be able to go there in Mount Elgon so that if there is any other person who is in Kimilili, they are able to combine and have that services offered alongside. And this is what also we are saying. We are also, doctors cannot be everywhere. Specialists cannot be everywhere. There are few in the whole country. But we are saying those we have in Bungoma must be able to serve the entire Bungoma, not a specific facility. That's what we are trying to put across. Yeah.
Waziri, maybe the issue, I don't know whether you have enough quarantine wards or facilities for suspects or maybe patients with Marburg, Ebola, and Mpox. 2, I don't know what measures you put in place to ensure that you curb the virus because we are living within the porous borders. I remember some 2-3 months down the line we had about 4 suspects and 1 fallen, but I think the 3 survived. So I don't know what mechanisms you put in place to ensure that this is being curbed from our international borders, given Malaba and Luhaha.
Okay, thank you very much. And I think we have a team here because we have a surveillance team and a committee which is actually on constant surveillance mission over the cell. And I think you can just give a brief on how far they are on that subject of surveillance.
Thank you for that question.
Light is too much there. Maybe if you can just swap with the doctor. Well, I can sort of.
Could you introduce yourself?
Yes.
Just a moment.
Yes. I'm Mwambusu Moses. I conduct malaria program and also surveillance services in the county. Number 1, you have asked a very good question about the Marburg and the COVID, the Mpox. We have a team on the ground and we have the structures right from the county level up to the sub-county level. We have the county surveillance officer. This officer coordinates the surveillance activities in the entire county. It trickles down up to the sub-county level where we also have sub-county disease surveillance officers. These people do surveillance by moving around. And by these, they link up with the community strategy. Those are the CHPs. At this level, any suspect within the community is reported to the sub-county surveillance coordinator. And we rely on the community because of this factor we have. There's something in surveillance we call the rumor log. We have a register in every sub-county where any client from the community, when he has any information about any illness, any strange illness, he reports to the health facility. At that particular level, we consider that one to be a rumor. But again, it's important because it enables us to move to investigate this rumor. And that's how we trace our cases from the community. So any case identified from the community, the information is communicated to the sub-county disease surveillance coordinator. The sub-county disease surveillance coordinator is well equipped with the sample taking. He links up with the laboratory department. Then they pick the sample from the suspect. After screening and confirming that this suspect meets the basic threshold for the suspicion of the case that is being reported. Because for every case, we have a case definition for any case under surveillance. So based on the case definition of that particular case under surveillance, the sub-county disease surveillance coordinator picks the samples, then refers them within 72 hours to KEMRI, either Kisumu or Nairobi. So that's how we manage to do our surveillance and monitor any strange illness within the county. When we come at the port of entry, that is, for Bungoma, we have the Lohaha. We have also the Malaba, which also serves, a bigger chunk of it serves the Bungoma County. We have the port health officers who are based there. The port health officers are under the national government. The national government has equipped them with all screening gadgets. Any case, like for example, any case coming from our neighborhood, that's Uganda, entering the country, first of all, it will be spotted by the officer at the port of entry, that's Lohaha, who communicates, because we take all the details, where is this case traveling to? If this case is destined to end up in Bungoma County, we will communicate with the county disease surveillance coordinator, who will take the details of that case. If within Bungoma County, if this case is going to Naitiri, is going to Mount Elgon, we shall inform the surveillance officer at the specific sub-county where this case, and up to even the locality. And from there, this case is put under surveillance. You talked about the isolation facilities. Number one, you remember when we had COVID. COVID came in a big number. That was a pandemic. Mpox is not a pandemic. But still the same, when the numbers are bigger, we always have a provision for how we can isolate these cases from interacting with the general public. Like when we had the COVID, we had Webuye Health Center, which was picked out as a facility to serve as an isolation center. And even right now, if there is that need of big numbers of the Mpox or any other viral disease that is within the population, through the CEC, we will set a committee and they will identify a facility that will be gazetted specifically for that purpose of isolating. But for now, because the numbers are not alarming, we are advising the cases that have been already suspected in the county. We are doing home-based isolation because of the facilities. And we have our officers, just the way I've mentioned, they are following up them, they are monitoring them, giving them all the instructions at that household level, making sure that the conditions are not transmitted to the family members and the general population around.
Could we be having any victims or maybe suspects right now?
Okay, we have those ones. 4 of them have been confirmed positive and they have been isolated in the household. We are monitoring them and they are doing well, and our teams are visiting them.
So what's your message to the public?
My message to the public is, one, if there's any person feeling any signs that he is sick, not being well, we recommend that you move to the next facility, the nearest facility, because from that nearest facility is when that health practitioner will be able to identify what problem you're having. Because nowadays, any illness that you're suffering from, any time you move to a health facility, it's the health officer from that facility who will subject you to the screening, so that whichever the condition you'll be having, he knows where to refer you. If it can be managed at that facility, then it will be managed. If it can't, it will be referred to the next level. So we are encouraging that all the committee members be vigilant.
Thank you. We would have had enough time, but just because that our timetable seems to be not on our side, we have many things to do. We have the president down in Busia. We have, I think, the Minister for Energy.
I still have 2 questions. One question is, there's a concern from one of my followers who asked there was a day a patient was dumped somewhere in Buye. What is the status? Number one. Number two, tell us about Jubilee cover for staff. There have been some complaints I've received about it, so I don't know whether it is working now.
Thank you very much, and I appreciate that. I think the case in Webuye, I think that time I remember I was in Mombasa doing a training, and I was called and I issued a statement indicating that the patient was recalled to the hospital so that he's properly reunited with the family. And I can confirm properly that the patient was reunited with the family, and the case was settled properly. With the Jubilee insurance, yesterday I confirmed with the Department of Public Admin, it is functioning. So the staff will continue to enjoy the services.
Maybe in times the government has got issues with communication. Did you communicate to your staff and tell them where the problem was?
As I said, it depends on this cover, how you are enjoying it. Like for example, SHA is also providing a medical cover, which I've already indicated to you that we have also had a communication to deal with that in terms of every 9th it is cut off. I think that only communicate to SHA. With the Jubilee, I think it's managed under public administration, and as far as I'm concerned, they have communicated some of us to indicate that it's operational. So we expect that staff will continue enjoying the services. Yeah.
Thank you.
Thank you.
And the next one.
Uliza ni watu wamekaa
Thank you very much.